This podcast is for informational and educational purposes only, and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients. Patients in need of medical advice should consult their personal health care provider. From UPMC Children's Hospital of Pittsburgh, welcome to That's Pediatrics. I'm your host, John Williams, Chief of the Division of Pediatric Infectious Diseases.
And I'm Steph Dewar, Associate Professor of Pediatrics and Vice Chair of Clinical Affairs and Director of the Pediatric Residency Program. Thanks again for joining us. We're here today with Dr. Chong, who's the Chief of the Division of Pediatric Allergy and Immunology and an Associate Professor of Pediatrics at the University of Pittsburgh School of Medicine. One of her roles is to participate in the Center for Rare Disease Therapy here at UPMC Children's Hospital of Pittsburgh. Dr. Chong, welcome so much. We're so excited to have you here and hear your story and hear about some of the exciting things that are happening in allergy and immunology at Children's.
Thank you so much for inviting me. I'm glad to be here.
So just tell us a little bit about your division and what the main functions and types of patients that you're taking care of here.
So allergy and immunology is always so interesting to me because they don't seem really that related to each other. And in other countries, so in Korea and other countries that I know of, they actually don't do allergy and immunology together. So allergists are a separate training program. Immunologists are separate. And most of the time, the immunology is lumped in with rheumatology because they're both sort of opposite ends of the immune system, right? One is an overactive immune system. The other is an underactive immune system, but it's all along the spectrum of the immune system. Here, we are combined, as most places are combined, but we have allergists and immunologists here who take care of a whole wide spectrum of disease. So we see a lot of asthma here. Dr. Larkin has a severe asthma clinic that she shares with Dr. Forno from pulmonology. So it's actually one of the few pediatric joint severe asthma clinics in the country. So it's pretty awesome that we have that right here. We also have a food allergy center where we participate in about 6 clinical trials in food allergy tolerance. And one source of pride for me is that we were the one of the only regional, like in all of Western PA, participants in the recent food allergy clinical trial where they had patients eat a little bit of peanut protein every day to help tolerize them to accidental peanut exposures, and that just got FDA approval. It's called Palforzia. It's probably going to hit the market soon, and we were a part of that study. We have patients who are already benefiting from that, and I really like that we get to do that. So we also take care of eczema. We take care of the whole atopic spectrum, we like to say. And on the other side, we also deal with the immune system. So when I came about 2011 or 2012, the allergy immunology clinic was kind of just all mixed together. So you never knew what you were going to get that day, right? You could get an asthmatic, you could get someone with a food allergy, but you could also suddenly get a very complicated patient who has a stack of notes 500 pages deep, who's had 15 evaluations by other physicians who doesn't have a good diagnosis, right? All they know is they get sick a lot, they have a giant spleen, and they're on immunoglobulin replacement. So what we did is we decided to separate those clinics. So now we have a clinic for primary immunodeficiency, and it's the first Monday of every month. And those patients all are chosen and selected to have problems with their immune system, either for evaluation referred from a physician, or they have a known diagnosis. And it's really helped the way we treat these patients. It's allowed us to create a care team for these patients. So we have a care coordinator who comes. She will tell me all of their IgG levels. What was the last dose of IVIG? This is a patient who had a bone marrow transplant 5 years ago. 1 dose of rituximab, never made antibodies again, right? So we know about all of these patients. We discuss them as a group. And because these patients are separated, suddenly there's interest from fellows who never wanted to learn anything about peanut allergy, such as like rheumatology or hematology, who say, well, I'm actually interested in immunodeficiency because there's a lot of crossover. So now we have people rotating and learning in that clinic from other services, which I think is really great to have that multidisciplinary approach to these patients.
So it sounds like, it's interesting that there are two specialties together that don't have, in some ways, a ton of overlap in terms of the clinical diseases. For the immunodeficiency patients that you see, could you talk a little bit about the kinds of things you see and how common are those? We're sort of talking like boy in the bubble disease, things like that, right?
Right, exactly. So we do, so there's only a handful of centers in the state of Pennsylvania that actually have the capability of treating severe combined immunodeficiency, which is bubble boy syndrome. And our state started screening for SCID in 2013. And what's awesome is that starting 2019, all 50 states are screening for SCID, which is amazing, since the pilot in 2008. But what's sad is that our state is one of the few, if not only, states that didn't make it mandatory. So our state put it on the mandatory follow-up list, meaning if you choose to screen, then you better follow it up. But we're not going to pay for it to be screened. And so that's one of the things that we're working on actually right now, is to figure out how can we close this gap. And so we see these patients who are being screened, but for the ones who aren't, how are we going to help take care of these patients? And it so happens that Pennsylvania, as you guys probably know, has the largest Amish population in the world. And these patients, the vast majority of them actually are not being SCID screened. Although now most of them are getting some sort of screening, but because it's not mandatory, it's being missed. So we have a task team now actually with, I contacted the immunologists at CHOP and at Hershey to see if they're getting these Amish kids with SCID. Because founder mutations, actually, their incidence, when we try to look at the data, they should have almost 1 in 4,000 births with SCID, where the general population is around 1 in 50,000. So the rate of SCID is higher in this population. And we're not getting these kids. And so where are they? What's happening to them, right? So we are actually working together right now to figure out a way to get everybody universally screened. And that's one of the big projects that we've taken on. But it's exciting and it's necessary to literally save lives.
Yeah, I mean, that would be really important as an infectious disease doc. If these kids are caught early, I mean, I've seen this where if they are not diagnosed, and the babies with severe combined immunodeficiency can show up later in that first year of life with overwhelming infections.
Exactly.
And it's really late at that point to intervene.
Exactly. And there's data that demonstrates that patients who were diagnosed under the age of 3 months had a much higher survival rate. And that's partially because they aren't sick by 3 months, right? So when they come in and they already have PJP, or I still like to call it PCP. Do I have permission to call it PCP,
We're
Dr. Williams?
To call pneumocystis pneumonia. We're allowed to still call it PCP because we can say that as for pneumocystis pneumonia. I, like you, grew up calling it PCP. I can't call it PJP just because people changed the name of the germ.
This is so great that I didn't even know we were supposed to call it PJP, so I'll call it PCP.
You can stick with PCP
That's
also.
fantastic. Wonderful. So I just want to change gears a little bit and maybe have you share with us a little bit about the Center for Rare Diseases. I mean, I think SCID is sounds rare, but a little less rare in the Amish population. But is there a different group of diseases that are focused on in that center?
Yeah, so actually we participate in the Center for Rare Disease, but the center seems to be a little more geared for treatment. So patients who are already diagnosed seeking new and innovative treatments that we can provide here at this hospital. But what the genetic counselors who run the service were telling me is that people are asking to come here for an actual diagnosis. And there wasn't like a clear established pathway for this. And it just so happened that Scott Canna, who was already on this podcast, also realized that there's this untapped population that we really could be helping. And he came from CHOP, where they had a dysregulated immunity team that they called DIRT, which we are trying to pick a better name than that. And that's something that we have the capability of doing here, right? We have such a wonderful collaborative environment with so many different disciplines. And so we decided to create an offshoot of the Center for Rare Disease Therapy that is going to focus on the diagnosis and management of those with immunodysregulation. And so I think that's a really exciting part of immunodeficiency, because so many people think, well, if you have an immunodeficiency, that you have to present with infection. Otherwise, how can you have an immunodeficiency? But there's a good proportion of patients who present with autoimmunity, autoinflammatory symptoms first, right? And in fact, one recent study said that 10% of all PID comers present with cytopenias first before infection, right? So these are things that we don't always see in our clinic because they're not coming to our clinic, right? They're going to other clinics. And it's not until they're getting very sick or they get some sort of therapy to help modulate their immune system because they're diagnosed with autoimmune disease and they don't recover very well, right? That somebody realizes, hey, what's different about this person? So we're collaborating now. It's with rheumatology. We have someone on from the PICU. We have GI involved. We have liver specialists. We have bone marrow transplant specialists. And our goal is to take these complicated cases that people see, right, that don't have a good unifying diagnosis, and bring them here where we can spend a day or 2 days with them, where they can visit all of the services and we can work collaboratively to try to come up with a way to look for disease, either through commercial CLIA certified testing, but also to hopefully incorporate a research component where we can actually get samples from patients and do research studies that only we have access to, that could help in diagnosis or even management.
So I'm wondering, I know recently there's been in the news about a shortage of IVIG, and I'm just wondering if that has impacted your division and your clinical work at all.
Yes. So it is amazing how widespread this IVIG shortage is. And so IVIG is interesting, right, in that it actually comes from donors, so plasma donors. And the time from you going right now to donate your plasma because of the shortage to the time it will become a product is a year. So even when we have this shortage, the processing and everything takes so long that it's not something that's going to be solved right away. And because of this IVIG shortage, we're very lucky at UPMC in that we have priority, that some hospitals may not have the privilege of having priority from the manufacturers. So we have been able to manage our shortage. But I've talked to many immunologists around the country at many academic centers, and they had a month or two where they had almost no supply. I just saw a patient the other day who was being seen somewhere else, and they couldn't get immunoglobulin for 2 months because of the shortage. And so then their insurance canceled them, saying they're non-compliant. And so then it took even longer to get them back on IVIG. So these are the things that can happen from these shortages. One of the things I think that we're working on here, well, in the immediate to-do list, is how do we curtail the immediate use of IVIG so that we have enough for those who come in and need it urgently, right? So Kawasaki,
sure,
we want to always make sure that we have a supply of IVIG for these patients. And so that means that we have to look at these diagnoses of people coming to our infusion center as an outpatient that are scheduled and say, which of these patients can we reduce, or can we push off their immunoglobulin? Instead of other institutions, which I'm being told by someone from the Immune Deficiency Foundation, they were just cutting everybody's dose, which is not clinically the right thing to do, right? Because depending on the diagnosis, the dose can be very different. So we started creating some emergency guidelines on IVIG usage, but this really led me to look and say, there's like almost no guidelines on IVIG usage, right? So how do we really know if we're using this effectively so that we don't keep running into these situations in the future? And so we are hoping to meet with every group that prescribes a lot of IVIG and talk to them about their protocols and examining the protocols and seeing, are there smarter uses for IVIG, or are there ways that we could make this more manageable?
So there's our shameless public health plug for all of our listeners to be blood donors or platelet donors. So I was a platelet donor for years in medical school. It's not hard. You just go and they hook you up to the machine to draw your blood. They put on headphones. You can watch a movie and relax for, an hour or so. Good times. So Dr. Chong, you mentioned, there's sort of these two aspects of your field of allergy and immunology. I'm curious which side you came in on and how you got interested in the area that you're in. That you mentioned there are not many academic centers in the country that have a program like yours with a person like you really interested in this. How did you get there?
So, honestly, my life story, I can tell you my life story.
Cliff's Notes version is fine. It's a podcast.
So, I came when I was 5. My parents, neither of them went to college, and my mom really didn't go past the 6th grade. And they brought my sister and I here for an education, and so they run a little convenience store. And when it was time to go to college, I just said, I'll go to whoever gives me money and is not far away. And so I ended up going to VCU in Richmond, and I had a job at Sears after work, and I saw an ad that said that they needed a research assistant in a lab, and they were going to pay like $9 an hour, which is insane, right? So I quit my job and I got hired in this research lab, and it happened to be the research lab of Dr. John Ryan, who does mast cell biology. And it was wonderful. I just absolutely loved it. It really made me realize how not smart I am when you go in there and you're dealing with these complicated things that you've never had to think about before. And so then, with his encouragement, I ended up doing the MD PhD program with him. And so I stayed in Richmond, which is like an hour from my parents. I did the MD PhD program where I did 6 years. So I did 3 years of med school and 3 years of PhD and shaved a little off. And then I said, well, I guess I should go somewhere that has a lot of research funding, but I want to do peds because you can do allergy immunology from peds or adults. So I ended up at University of Chicago, where I did my peds residency. And after that, when I said, okay, I'm going to study mast cell biology, who does mast cell biology? It was Brigham and Women's Hospital. They have tons of mast cell biology. So I ended up in Boston. And it's during that time that I started clinically training as an allergist. And I thought, allergic rhinitis is so boring. I don't know how to feel about this because I've been studying mast cells forever, but I just don't think I can prescribe Flonase and allergy shots my whole life. I don't know what to do. And that's when I got a patient. I got a call about a patient who was an 18-year-old at the time who was status post common gamma chain SCID and had a transplant at 3 months of age, and was now coming in with waning immunity, which has been demonstrated in these SCID kids that these 14 years post-transplant, you can have the thymic output of a 80-year-old. So he was having some waning immunity, but it wasn't really recognized as that. And so he ended up getting diagnosed with large cell leukemia, but when they went to look at him, it was all polyclonal. He didn't have anything monoclonal. And so it was by digging through and talking to people that I realized that he probably needed another transplant. And so I reached out to one of the transplanters at Boston Children's, Dr. Sun Young Pai, and I realized that this is a really fascinating. These patients are such a perfect mix of clinical and bench work, right? Because these patients are sort of like the knockout versions of mice in a way, where we can see what these genetic defects are doing in people. And by knowing that, we can find ways to treat them and fix them. So I really just started changing the way I thought about things. And when I got recruited here for my first big girl job as an attending, I decided that I think I want to change my clinical focus on immunodeficiency. And that was about 8 years ago. And I have learned so much about the immune system and immunodeficiency and how it works with the patients and the value of precision medicine. And it's just been amazing.
Wow, that is a great story. I'm sure your parents are very proud of you. That's really impressive and fascinating, actually, to kind of end up where you are now and the turns that your career took. Well, I'm really happy that you spent the time with us today. It's fascinating to learn about the things that are happening here at Children's.
Yeah, thank you so much for joining us, Hey. And not only was that a great story, but I didn't even know until just now, I also went to med school at MCV VCU in Richmond.
What?
Yeah.
It's a small world.
A small world.
That's awesome.
Well, thank you so much for coming to join us. You can find other episodes of That's Pediatrics on iTunes, Google Play Music, and YouTube. Be sure to subscribe to keep up with new content. Please leave us a review and tell us what other topics you'd like our experts to cover.